Good morning, everyone. Today, Payal will be presenting the case and will be moderated by Professor R.S. Sastry, Professor T.D. Yadav, and Professor Ramakrishna Prabhu. It's all yours. You can take over, Professor Sastry, Professor T.D. and Ramakrishna Prabhu.
Good morning, everybody. Go ahead, Payal.
Good morning, sir. My patient is a 61-year-old male, resident of West Bengal, retired constable by occupation, who presented with yellowish discoloration of eyes and urine in past 3 months and loss of weight and appetite in past 2 months. Patient presented with was apparently all right 3 months back when he noticed yellowish discoloration of eyes and urine, which was gradually deepening, which was followed by generalized itching and clay-colored stool. Here, I would like to know about the severity of pruritus, whether it was affecting disturbing patient's sleep also. He also had complaints of loss of appetite and unintentional loss of weight of 5 kg in past 2 months. There is no history of abdominal pain, no history of altered bowel habits, GI bleed, no history of nausea and vomiting or early satiety, no history of any previous blood transfusion or abdominal distension, no history of any drug abuse or alternative medication intake, no history of respiratory discomfort, hemoptysis, bony pain or backache. I would like to know about the history of fever. He visited local hospital with above complaints and was evaluated with few blood investigations and referred to higher center. He was evaluated at tertiary center with imaging. He underwent an endoscopic intervention and stenting to alleviate jaundice. 2 days later, he developed abdominal pain and blood tarry stool. A fall in hemoglobin was noticed and he received 2 units of blood transfusion. He again underwent an endoscopic intervention to control blood loss. 2 weeks later, he developed yellowish discoloration and episodic fever spikes. He underwent a repeat similar endoscopic intervention and stent was exchanged, followed by which his fever spikes resolved. At presentation, his yellowish discoloration of eyes and urine has resolved and is asymptomatic. Patient is a known diabetic since 10 years and is on OHAs. I would like to know about any recent change in the diabetic status, whether he requires insulin in the recent history. There is no history of similar complaints in past. Patient underwent laparoscopic cholecystectomy 12 years back for symptomatic cholelithiasis and was uneventful. There is no significant family history. Personal history, patient has adequate sleep. Appetite, which was reduced initially, has now improved. Bowel and bladder habits are normal and regular. Patient consumes mixed diet and there are no addictions. Summarizing my history, my patient is a 61-year-old male diabetic with history of painless progressive cholestatic type of jaundice for past 3 months and significant loss of appetite and weight for past 2 months. Status post ERC stented, complicated with hemophilia, managed conservatively. Status post stent exchange, managed with stent block, currently asymptomatic, and history of laparoscopic cholecystectomy 12 years back, which was uneventful.
Yeah, Dr. Payal, see, right now what you have presented is what has been given to you. Go to your first slide. Yeah. So now, can you go to your second slide? Sorry. Now, in this slide, what additional information would you have asked from your side so as to come to a possible etiology? Because right now you are just giving us what has been told to you. What additional information would you have liked, other than just knowing about whether the patient has a fever and pruritus which was disturbing the patient's sleep? Any other history which will make you point towards a particular diagnosis right now, because we are completely blind about the right. Yeah.
I would also like to ask about any past history which was suggestive of pancreatitis.
Pancreatitis is the etiological agent directly.
Chronic pancreatitis.
Okay. Would you not like to know the characteristic of jaundice, or whether the patient had a characteristic of pain and type of pain the patient had?
The patient doesn't have any abdominal pain, sir.
So patient with a painless jaundice, right? So would
Yes,
you want to characterize these so as to find out the etiology? Since you're just telling us what has been given to you. So what additional questions you want to ask to come to etiological agent? Like whether the patient had jaundice. You just say it's a deeply joined jaundice. What is happening to the jaundice? Or what is in the past? With the jaundice?
In the history, it is given that the jaundice was gradually deepening. So it is a progressive type of jaundice, painless progressive jaundice. For etiological workup, the histories that have already been given are regarding the with the history, I would say that it is a cholestatic type of jaundice. And since it is painless progressive, malignant etiology is to be kept in mind. The malignant etiologies like CA pancreas, I would like to keep in mind. And for that, I would like to know about any past history of chronic pancreatitis. Then other than that, I have already been given about the history of drug abuse, which can cause intrahepatic type of cholestatic jaundice.
No, patient has no history of drug abuse.
Yes, sir. There is no such history, sir. And history of pain abdomen is also not there, sir. And history of nausea, vomiting, early satiety is not there, ruling out any gastric outlet obstruction. There is no history of any blood transfusion, ruling out any possibility of chronic hepatitis B infection and further leading to TLD and causing this jaundice.
Dr. Payal, you are mixing so many things, drug history, drug no. Why are you coming to chronic hepatitis? You said that there is no history of this, so I am excluding chronic hepatitis. What do you mean by this statement?
Sir, in the etiological workup for this patient, I would like to keep the possibility of malignancy.
You said just recently, you said that because of certain reasons you are keeping obstructive jaundice as a first cause of this particular problem. Then now by one you are saying I am excluding this because of this. Why hepatitis? What are the features which are suggesting hepatitis in this patient?
There is no feature of hepatitis.
One particular thing, then why you talked about there is a history of drug abuse, which drug abuse is called this type of features? Drug abuse means what? You are thinking about drug abuse leading to the obstructive jaundice, or you are thinking about drug abuse leading to hepatitis? What is the message from this statement?
Cholestasis, sir.
Cholestasis. So how drug abuse produces cholestasis? So unnecessary, I think, statements. Now you stick to the what history you have been provided and what extra you want to know, which can contribute in making your diagnosis clinically. This is what is the way of presenting history. Not that each and every point you have also said that I want to know the severity of the pruritus.
Yes, sir.
Tell me why how it is relevant.
Sir, based on the severity, if the pruritus is intractable, further management would be planned, sir. Patient might need stenting.
That is given in your history. That is also in your history, no?
Yes, sir.
In the history that patient was stented.
Yes, sir.
So, what other?
Is pruritus quantifiable? Is there any grading of severity? Isn't it totally a subjective thing? And it's not, okay, it's important if you have only pruritus and you want to have only a palliative treatment, that's a far-fetched thing. But intensity of pruritus may be a little too, much of a splitting of hairs. Okay, Yeah, you did mention about history of fever and recent aggravation. No, you wanted to know about recent aggravation of diabetes, which are quite relevant. So, what provisional diagnosis would you make out of this history?
Sir, my diagnosis is a case of extrahepatic biliary obstruction with likely malignant etiology, with first possibility being periampullary carcinoma, second being cholangiocarcinoma, and third being CA head of pancreas.
Is it that simple to have a periampullary or a CA head of pancreas or a cholangiocarcinoma at the lower end, just based on history?
Sir, in periampullary carcinoma, again, I would like to keep the ampullary carcinoma as the first diagnosis, because the patient has painless jaundice. Painless jaundice is seen in around 70% of patients.
That is okay. For any lower end obstruction, it is okay. All this history is supportive. See, in your diagnostic workup, you go in a stepwise manner, coming from a broad diagnosis to a specific diagnosis. So, wouldn't it suffice to say that it is most probably a lower end obstruction? To be very specific, whether it is a cholangiocarcinoma or periampullary carcinoma or a head of pancreas, may be a little too much at this stage without building up enough of the clinical features.
Yes, sir. Especially lower cholangiocarcinoma, how will you differentiate from periampullary? Is it not a component of periampullary lower cholangio, or there is some definition about periampullary tumor?
Periampullary tumors are defined as tumors occurring within 2 centimeter area of the major papilla, and distal or lower end cholangiocarcinoma can occur extend up till the junction of cystic duct and CST.
Cystic duct sometimes is very close to the porta, and it will not come into 2 centimeter of the diameter. Please, before you give a statement, just think about that. Cystic duct is sometimes somewhere in the close to the common hepatic confluence, about 1.5 to 2 centimeters. Sometimes, very rarely, it come in the retroduodenal area. That is the rest of their thing. So it will not come into the lower cholangio where cystic duct is inserting. Below that, you say that it comes into periampullary. Might come mid cholangiocarcinoma, but periampullary component involving cystic duct insertion and below onwards is something very unusual thing to happen. So as sir is saying, being so specific that lower cholangio, even it can be ductal carcinoma of the pancreas can be part of that. But when we talk of head of pancreas cancer, then usually we think about there is a mass lesion in the head of the pancreas. So why you are keeping, because it is painless progressive jaundice. What are the other things which can happen when there is a painless progressive jaundice? Forget the treatment being given to him.
Sorry, sir?
What are the other differentials when there is a painless progressive jaundice? In terms of malignancy only. You said my malignancy is the first. We agree with that type of history is there.
Malignancy is the first. Sorry, sir, I didn't get the question, sir.
I am saying that this patient, you said that I am keeping a lower ampullary tumor first because this is a painless progressive jaundice. Am I correct?
Yes, sir. Short duration of history, painless progressive jaundice, and significant loss of weight and appetite.
My question to you is,
why is it not a proximal duct obstruction?
Why is it not a?
Obstruction also you should be able to guess.
Sorry, sir.
The level of obstruction. Is it a proximal obstruction? Where
They
you
believe in the jaundice with endoscopic intervention, and patient did not require like PTBD or percutaneous intervention. So likely it is a subhilar or lower end block.
isn't it a flimsy thing that proximal obstructions require only PTBD and not endoscopic intervention? Endoscopic intervention, does it rule out a proximal obstruction?
It does not rule out, sir. But
No, it doesn't.
like
So you need to have a broad view at this stage. Okay, there was some post intervention. There was a problem. So
Yes.
how do you put this in your assessment? See, there are two events, one bleed and then fever.
First event was was likely a hemophilia. Secondary to it can be secondary to sphincterotomy, or considering the history, it can be a bulging ampullary tumor. In the pre-cut, it might have bled. So that is why I kept the ampullary carcinoma as the first possibility in periampullary. And second was a stent block which was managed with stent exchange, causing
Right.
cholangitis and procoline.
Periampullary carcinoma that would bleed post ERCP and intervention. Can a normal sphincterotomy also bleed?
Yes, sir.
So it doesn't really point to only a periampullary. So what are the instances where a bleed can occur?
If
The
there is-
factors you would consider when there is a bleed.
If there is a bulging ampullary growth and the pre-cut is made through the tumor, or if a deep incision, sphincterotomy is made, or if there is a lower CBD cholangiocarcinoma also, and if it is being cut through, the tumor is being cut through, then there are chances of bleed.
Payal, it is good to classify. See, when you have various reasons, could it be a hematological reason? Coagulation problems? How severe is the bleed in general post ERCP? Is it a life-threatening bleed? Is it a moderate bleed or is it a mild bleed? That assessment is also important. So if
Also, this patient was just admitted. Yes, sir.
It could be hematological reasons, it could be disease related, or it could be technical related. Isn't it?
Yes, sir.
So it
Also,
doesn't really
Payal,
point
if you
to
see,
that answer.
this patient was admitted and directly sent for ERCP. So there is no a place that it says that the patient was stabilized or something. Maybe the patient's coagulation profile, like Dr. Sastry is saying, may not have been corrected. And that sphincterotomy itself might have caused so much of bleed that the patient required 2 units of blood transfusion. That is all the patient needed. And then the second episode, maybe because of the clot, which have blocked the stent, and then the patient must have gone into cholangitis. Okay, go ahead. Go to the next slide. Yeah, this is what it says. No, just patient required 2 units of blood transfusion, so the patient bleed must have been significant and was required an endoscopic control. Okay. So what do you interpret from this present slide? A patient developed a block of the stent, and then
He underwent stent exchange, and after that he was asymptomatic.
okay.
In a patient coming from this part of the country, you have not even tried to consider carcinoma gallbladder. Can you please give me the regions? Give us the regions for that. Epidemiology is also important when we are talking about differentials, and we should have regions to exclude from the differential discussion. Hello, Payal.
Yes, sir.
Am I audible?
Yes, sir.
I am saying the patient is coming from a belt, north and east, from where is this carcinoma gallbladder is common, and I hope you know that commonest cause of surgical obstructive jaundice in these areas is carcinoma gallbladder. Can you please give the reasons why you have not taken into the differentials?
Sir, there is no history of past pain, abdomen, or biliary colics in this patient.
While you're missing one important thing, that the patient had a laparoscopic cholecystectomy 12 years back.
12 years back, sir.
Is it possible to have CA gallbladder 12 years after a cholecystectomy?
No, sir. Less likely.
Yes. So that should be the first, argument, isn't it?
Yes.
Okay. Go ahead with your examination and other. Let's get ahead.
On physical examination, patient is conscious, cooperative, oriented, time, place, and person. BMI of 23.1, well built and nourished. ECOG status is 0. Threshold time is 44 seconds. There is no pallor, itching, cyanosis, clubbing, lymphadenopathy, and edema. Vitals are stable. There is no enlarged left supraclavicular nodes. No signs of malnourishment or visible scratch marks. No signs of liver cell failure. Abdominal examination inspection other than healthy port site scar at previous laparoscopic cholecystectomy, inspectory findings are with normal. Palpation, abdomen is soft, non-tender, liver and spleen are not palpable, no palpable lump. Hernia orifices and external genitalia, there are no palpable abnormalities. Percussion, liver upper border palpated at 5th intercostal space in right mid-clavicular line. Liver span is about 13 centimeter in right mid-clavicular line. Flanks are tympanic. Auscultation, normal bowel sounds are heard. Digital rectal examination, gloved finger with normal feces stain. Normal.
Your diagnostic workup. These are all normal. It's does it add anything more? Is there any reason to change your diagnosis?
No, sir.
No. ESBO, likely malignant etiology. Okay, still only there. The periampullary cholangiocarcinoma, we argued that it may not be quite relevant at this stage. See ahead of pancreas here. Okay, so what do you like to, how do you like to proceed?
I would like to review the patient's previous investigations, his initial blood investigations that were done, and imaging prior to the endoscopy that was done, and ERCP, both first ERCP, then what was done in the endoscopy, endoscopy post hemophilia, and the second.
So you want to basically see all the investigations. Let's go one by one. So what is the first investigation you want to see?
The blood investigation.
Okay.
In LFT, before stenting, patient has direct hyperbilirubinemia with elevated with transaminase and INR is in a normal range.
What is interpretation of this one?
It is a patient is having cholestatic type of blood picture, obstructive jaundice type of blood picture. Albumin is almost not.
Transaminasemia.
Sorry, sir.
Transaminasemia. Why this is there?
It suggests hepatocyte injury, which can be due to subacute cholangitis kind of picture.
Okay, next, what do you want?
I would like to know hemogram if it was done at that time to know the TLC level.
So does it add to your help in making your diagnosis at the stage according to your sequence of the differentials?
It will just confirm whether patient had cholangitis prior to stenting or not. It won't tell about the etiology.
In the first history, you have got the history, and they suggest that this was the patient came only with the jaundice and the endoscopy procedure was done. There is no mention of any fever or anything.
Yes. Next, I would like to know about the imaging, sir, done prior to endoscopy.
What would you like to do in a case like this? What is the first imaging you would like to have?
I would like to do a ultrasound abdomen.
What all you want to see on ultrasound?
Sir, in ultrasound, I would like to know about the level of block, IHBRD. It can also tell the cause of obstruction, like gallstones, CVD stones, or any mass in GB fossa or in the biliary system. Liver SOL, ascites, and
Liver, you have, I think you should talk as you have made your differentials. So stone disease, you have not discussed. Gallbladder, as you said that this patient 12-year cholecystectomy has been done. So in the same line, as you are saying, making your differential, what are the things? First you said that I would like to see the liver.
yes, sir.
Liver is SOL and IHBRD.
Yes, sir. SOL and IHBRD, I would like to see liver. And then I would like to know about the level of block based on which in which part the biliary tree is dilated, and if there is any mass seen in the system.
How common is it to detect a mass in the head of pancreas in ultrasound?
It is not very common, sir.
No, there must be some criteria, some measurements. So I'm sure it's a 5 centimeter mass you should be able to detect. So generally speaking, less than 3 centimeter masses are not detectable on a routine ultrasound. So that would not rule out a head of pancreas. So you'd be looking definitely for a mass lesion in the head of pancreas. And if it is there, then it's definitely a significant mass. So that is the type of importance you would give. Okay.
So
Do you
what is
have
the next
some picture?
investigation if you want to do?
Sorry, sir.
What is the next investigation we will want to do?
In
Do we have some picture?
pre-stenting imaging, sir.
Yeah. Which investigation?
Can you have ultrasound which has been done? Yes. So you could always see that this ultrasound has mentioned so many things, including spleen, including echo of the pattern of the ecotexture of the liver,
Yes,
and
sir.
they have also talked about
So
pancreas.
what are the relevant findings in this which would lead you to further investigation?
Sir, actually in this ultrasound, the distal CBD is obscured and CBD is dilated. Likely it is a distal CBD block, but I cannot definitely say in this ultrasound because distal CBD is obscured. So I would like to know about the CT that was done. Triple C.
Would you like to have X-ray chest also at this stage?
Yes, sir.
We always discuss about this when when your differential is a pancreas or head tumor, also one of the differential.
Yes, sir. I would like to know about the chest X-ray.
And don't just say CT. What kind of CT would you like to have?
Sir, triple phase CT, sir. Since the ultrasound showed the normal pancreas, but still I would a pancreatic protocol CT would suffice. Sorry, sir. Pancreatic protocol CT I would like to.
Triple phase or pancreatic protocol?
Sorry, sir.
Is it triple phase or pancreatic protocol?
The pancreatic protocol.
What is it? What is the difference?
In triple phase we have early arterial phase, then a portal phase and a venous phase. In pancreatic protocol, other than the pre-contrast, we have a late arterial or pancreatic phase and a venous phase, portal venous phase.
And the cut size also is different, no?
And in pancreatic protocol, preferably 1 mm slice thickness should be taken. 64 slice CT should be there. The dye that is injected is at a higher rate, that is around 4 to 6 ml per second. Yes, sir.
Okay.
At a dose of 1 mg per
Let
kg.
us see the CT.
Sir, this patient was evaluated outside, sir. We have CT images after stenting it was done. Could you able to retrieve those images soon?
So do you think this is appropriate to get a CT after stenting in a
No.
patient, especially would have stented this patient before?
I would have got a CT done prior to the stenting, sir.
Yeah,
Because,
more so like Dr. Yadav pointed out, this patient was not in cholangitis at all. WBC count is also around 10,000. With no history of fever.
There was some history of fever.
That
We
is
do
after.
not know the time sequence of fever and the stenting.
Yeah, it was post stenting the patient had fever.
Okay, yeah.
Okay, so we don't have a CT, we have a CT post stenting.
So what are the problems of post-stent CT?
since there is a stent in situ, it will our finding mass, small mass can be missed because of the artifact.
Artifacts one. Any other thing?
The level of obstruction would not be clearly defined because the biliary system has already been drained.
Any other?
Okay, go
As
ahead.
it happened here, this patient developed fever. So the inflammatory changes around could obscure. So it would be difficult to differentiate between the inflammatory changes and the humoral changes. So these are the reasons why you would like to have an imaging first. Okay. Interpret this.
Non-contrast film, I don't have to. Coming to the portal venous phase directly. Portal phase. Visualized lung fields appear normal. Liver margins are regular. There is no IHBR. A stent is seen in situ.
So you will go directly to the portal phase, or you want to see any other phase before going into the portal phase?
Non-contrast, pre-contrast phase I would like to see. I'm not finding the pre-contrast phase here.
Okay, without pre-contrast, we have arterial phase, portal phase, and HRCT. Okay, out of these three, which one is the first one you want to see? What is the characteristic lesions are seen on a CT scan of a pancreatic lesions?
So in arterial phase, pancreas enhanced and the lesions are hypo.
So you should see the arterial phase first. No, you are going to directly the portal phase.
There is a mass in the head of pancreas.
No, go up, go to the previous one. Yeah, go up. Okay. Can you see, what do you see over here? Can you see the pancreas? Okay. Come down slowly. You can see the stent inside. Come down. Yeah. Can you see the C of the duodenum there?
Yes.
Yes. Can you see the mass over there now? What is happening over there?
Hyperenhancing.
Yeah. So you cannot see a hypodense mass, but definitely something else you can see. Go up. Go up. Yeah. Here. 1 minute. Come down. Yeah.
in arterial phase CT scan, what are the vessels you would like to see? And I'm not able to see properly the left lobe of the liver. Can you go up and see? Is there? Yeah.
There is volume redistribution, but here we cannot, and here we cannot clearly say whether there is atrophy, hypertrophy, because chordates look normal.
Down. So now, where are the vessels? What are the vessels we are interested in a patient with this type of history?
Celiac axis, CHA, SMA.
Can you see in the focus in the CT scan?
Yes, sir. This is the celiac axis, takeoff, common hepatic artery. This is proper hepatic artery likely.
And in
Right. Left. This is the SMA takeoff.
How do you identify the mass on a CT, pancreatic mass on a CT? What attenuation would be there?
So in arterial phase, it's hypoattenuation, hypoattenuating mass, unless it is a NET, which will be hyperattenuate. And yes, sir. In arterial phase, we don't have.
Okay, next.
are you seeing two stents in place, or there is only one stent placed in the common duct?
Sir, single stent, sir. It is pigtail type. It is curved here.
So what is this one going on in the pancreatic duct?
Yes, sir.
So I think the stent is quite a long one. It is going into the duodenum also.
This is, yes, sir.
Yeah, it's going into the duodenum. Yeah.
Yes.
Okay, let's go to the next phase. So what are you interested in looking here?
Portal vein, SMV, yes, and relation of the lesion to the vessels, its abutment, and even like if the angle contact is more than 180 or less than 180 with the artery and vein.
So what do you think?
So the contact is less than 180 degrees. Sir.
First describe the mass, please. Then other things are described properly.
Yes, sir. This is a mass, sir. This is portal vein. The angle of contact with the portal vein is less than 180 degrees.
Is there a fat plane between the portal vein and the mass lesion? That is the question. Now you see the.
Sorry, sir.
Is there a good fat plane between the portal vein and the mass lesion?
No, sir. There is abutment, sir. There is but the angle of contact is less than 180. There is no fat plane, sir.
So what is your diagnosis now?
SMV is also SMV is free, sir.
Okay.
Sir,
what about any lymph node? Are you able to see, or it only mass is thin? There is no nodal.
No, sir, I am not able to find notes, sir.
What is just behind the portal when you are go to the lower cuts? What is this area where you are pointing the?
But it is continuing, sir, with the pancreas.
It's not continuing that. And above other lymph nodes, what are other lymph nodes you would be interested in a patient?
SBN nodes. Probably it is a node,
Yes,
sir.
what is that? Yeah.
No.
That is what Dr. Yadav is asking you. That lesion which I just kept a point. No,
Yes.
above one. Yeah, yes. What is that?
Enlarged lymph nodes.
Yeah.
But,
Probably,
nodes. Other than that, I would like to see the SBN nodes, inter-ioto cable nodes along the SMA, and
what is
retro.
the diagnosis? Oh, very good. So what do you think this patient has?
Say head of pancreas, likely resectable.
Likely?
Resectable.
What about what you said is involvement of fat plane is lost between the portal vein or SMV and the mass?
Less than 180 degrees.
The loss of fat plane, or do you need to look for anything else in the SME?
Whether it is reconstructible or not. The proximal and distal parts are free.
Before that, any other morphological changes, the contour abnormality,
Abnormality.
isn't it? That's an important part. And the length of it,
Yes.
say yes, resectability. How can you say it straight away? It is resectable.
You have not decided upon the length of involvement also. No?
Not only length. If you see the in a patient like this, would like to have a recon pictures where you can clearly see how it is contour is getting deformed or not. It seems that there is a problem in the contour. It's not only fat planes are lost. It seems that portal vein seems to be getting involved. So for everybody, we always go and sit with the radiologist and see the recon pictures where you can clearly see how the portal vein is looking like and what is the clear length of the involvement, and then what is the is it constructible or not after the resection, and then how it is nowadays you know that there is a what are the definition of locally advanced and borderline resectability.
Borderline, according to NCCN, borderline resectable are those with where there is no evidence of metastasis, and there is involvement of if there is involvement of CHA or SMA less than 180 degree, or involvement of SMV or portal vein more than 180 degree, but it is reconstructible, or they, without any contour change, or less than 180 degree if there is any change in the contour, or if there is abutment in IVC.
If SMA is also involved, even less than 1 degree, it is a borderline resectable tumor.
If it is less than 180 degree angle of contact.
Which classification?
Not SMA, sir. Only CHA and
only you are saying right now, no, that SMA you are intermingling everything in one particular thing.
Okay, what are the signs of unresectability? Let us say start from that side. When would you say this is not resectable? Borderline, okay, you can have a lot of debate.
If there is distal metastasis or involved like liver SOL or peritoneal metastasis or omental metastasis nodules, or if there is in vein, if the vein is not reconstructible, then arterial involvement more than 180 degrees. Or if there is a long segment involvement of continuous involvement of CHA and DDA with celiac axis, which cannot be reconstructed.
Does the first jejunal vein come anywhere in the picture?
Yes, sir. If there
How is
is
it?
if there is a continuous involvement of SMV and first jejunal vein, and the first jejunal vein, if the it depends on the first jejunal vein anatomy also. Like if it is
So
directly,
what is the normal anatomy of the first jejunal vein and its significance in say, surgery around the uncinate?
involvement of first jejunal vein,
Anatomy first.
first jejunal vein usually normal, most commonly first and second jejunal vein arise as a common trunk from the SMV.
Is that true? Is the common jejunal trunk more common than isolated first jejunal vein?
I don't remember. There are 4 types.
Yeah, yeah. And what is the significance of first jejunal trunk? That is the first and second jejunal veins joining together.
So if we have to resect the first jejunal vein, there will be congestion in the limb that we are taking up for anastomosis. So we have to
First
check.
jejunal trunk, it is unresectable. And the location of first jejunal vein, how does it impact surgery?
Yes, sir, dorsal or ventral. If it is ventral, it is
Ventral to what?
to SMB.
To
SM?
SMA. How can it be ventral or dorsal to the SMV itself? You mean it's arising or draining anteriorly or posteriorly? Does it? Is it what you mean?
No, if it is ventral, will come across the first jejunal vein early.
Ventral to SMA.
Yes, sir, SMA.
Okay. So, how does it impact your surgery?
If it is ventral, will come across the first jejunal vein early during dissection, and there is high chances for us to ligate.
The first jejunal vein, and if it is not recognized, there is likely to be a large amount of bleeding while you are operating. One. Second, you have to know whether it is common with the second jejunal vein and is draining as a common trunk. And third, whether it is ventral or anterior, dorsal, because of difficulty in dissection and involvement of the resectability itself. Okay. What other things are you looking at in the CT? Are you able to see the first jejunal here? It may not be possible, but anyway, you should try and look at in head pancreatic lesions, particularly uncinate lesions. You must follow the SMA.
You go down close to the SMA, then you are finding some nodes along it or no?
Okay, what about the pancreatic duct? Is it important to look at pancreatic duct?
Yes, sir.
How does it signify anything?
So, in pancreatic head mass, double duct sign can be seen.
Okay, but how does it impact your decisions?
So, it will, if the pancreatic duct is dilated, the ease of anastomosis.
Okay, anything else?
Location of the lesion, whether it is based on whether pancreatic duct is also dilated, whether it is at the after the confluence of pancreatic duct with the CBD or prior to it. We'll get to know.
Okay,
It is
going
also
ahead.
important in chronic pancreatitis, malignancy in chronic pancreatitis and malignancy, the abrupt cutoff of duct or duct penetration. These are also things which you would look at in a pancreatic head mass. Okay. So how do you stratify this? Is it operable, borderline operable, or inoperable?
They're operable.
Operable. So how do you proceed now? Is this enough of a workup for treatment planning?
Sir, I would like to know about the current blood biochemical parameters of the patient and tumor markers.
Tumor markers. So how do tumor markers influence treatment planning?
Sir, if CA19 level is more than 100 international units per ml, then I would like to add staging laparoscopy to the surgery.
Okay.
More than 100, which recommendation? More than 100. Sorry, I just want to take back in a patient where it seems to be at least it is borderline resectable tumor. Not that it is a clear-cut fat plane. So, what are the current evidences in the literature that if you go direct surgery, you go for any type of neoadjuvant therapy?
For borderline resectable, the general consensus is to go for neoadjuvant followed by surgery, sir.
What is this tumor? It is clear-cut resectable. It is borderline resectable. What is your opinion about this?
Sir, borderline resectable.
Why you don't want to consider any of the trials? Are you aware of any two trials published recently?
Sir, the ongoing aspect.
Already published. There is nothing ongoing. Please discuss the results are published already.
Aspect 5.
When it was published?
ProPanc trial. ProPanc 3 trial.
Aspect 5 trial. Did you read that trial in terms of borderline or distinct tumor?
Sorry, sir.
Did you read aspect 5 trial?
Aspect 5 is for it is for resectable tumors.
Have you read it?
Yes, sir. It is for resectable tumors. Two arms are there. In one arm, there.
Your first statement is not correct. Aspect 5 is not for the resectable tumor. It is published now. It is about 2021. It has been published. It's not for resectable tumor. You had CA pancreas in your armamentarium when you were making differential diagnosis.
Yes, sir.
Resectable, there are other trials, but for borderline, you are doing another extreme. Now you are resectable trials. What are the outcome of that trial?
Sir, for ProPanc trial, they included.
We are talking about aspect trial. Don't mix the 2-3 trials, no. We are presently talking about aspect 5 trial, which is clearly for the borderline resectable pancreatic cancer, not even for the locally advanced.
Okay. Do you want to give neoadjuvant treatment in this patient or no?
Yes, sir.
What is the rationale of neoadjuvant chemotherapy in CA head of pancreas?
Sir, ProPanc phase 3 trial has suggested that for borderline resectable, they included both borderline as well as resectable pancreatic cancer. But for borderline resectable pancreatic cancer, the median survival.
I'm not asking about the indication. I'm asking about the rationale. Why do you want to give? What is your expectation after ASC?
There are more chances of negative margins after neoadjuvant therapy. More likely to get a R0 resection. Tumor biology can be assessed during the phase of neoadjuvant therapy. And
the first rationale is improve the selection of patients for whom resection will not offer a survival benefit. A negative rationale is more important. See, in any advanced malignancy tumors or potentially advanced tumors, what you want to do is to eliminate the patients who do not benefit by aggressive surgery. Isn't it? That is the first rationale. Yes, increasing the rates of margin and early treatment of micrometastasis. These are all part of the other rationale.
I think it would be relevant to have a report of the CT scan. Then we can understand because it was done after this thing. Can we have the report of CT scan, the CT scan? Encasing the main portal vein, MPD.
It is suggesting a borderline resectable.
Yes.
So what next now?
After
Yeah. What next? Yeah.
neoadjuvant therapy. But before starting neoadjuvant therapy, I would like to know the LFT of the patient and the tumor marker, and then we can go for neoadjuvant therapy.
Why
Important.
do you want to know the bilirubin level?
Before starting chemotherapy, whether the patient's bilirubin has normalized.
If it is
Would you want to tissue diagnosis
already
also? Because
stented,
I think you only said 3 things.
Tissue type.
Tissue diagnosis is also important in this. Okay. She wants to know the tumor markers. Which tumor marker?
LFT after 20.
Okay. CA99 level, bilirubin. Okay. Bilirubin is more or less normal, LFT is normal, INR is normal, CA99 is 27. What next?
Tissue biopsy.
How will you want to take a biopsy on this patient?
EUS guided.
Okay. So it is well to moderately differential adenocarcinoma. Now what?
Next, before starting neoadjuvant therapy, PET CT is preferable, sir.
Why PET CT?
According to NCCN guidelines, we should get a PET CT done before starting neoadjuvant therapy.
All patients are selected.
Especially in high risk patients, that is large tumor. For example, in this patient, there was 4 centimeter tumor, large tumor, large lymph nodes, or high levels of CA99. They have not defined the level, but and elderly patients.
Okay. Do we have PET scan?
Yes.
There is only lesion in the pancreas, no other lesions. So what type of chemotherapy, neoadjuvant chemotherapy you want to give?
gemcitabine based chemotherapy.
Gemcitabine. You do want to know the ECOG status of the patient? Does it decide what type of chemotherapy, neoadjuvant chemotherapy this patient will receive?
Yes, sir. If a patient is a good risk profile, there is then FOLFIRINOX based chemotherapy can be given. And
why did you say gemcitabine based? That is what is routinely given at your institute?
Yes.
Okay. Which is better, gemcitabine based or FOLFIRINOX?
FOLFIRINOX based.
Which trial?
Stenting the bilirubin has not come down significantly. Would you still go ahead with neoadjuvant treatment?
No, sir. No, sir. Bilirubin, we need to reassess the status of ISBRD if there are like before starting neoadjuvant therapy, bilirubin needs to be at least less than 5, sir.
Yes. It should be a durable biliary decompression. How do you assess after neoadjuvant treatment?
Again, a PET CT is to be done and CT scan is to be done around 4 to 6 weeks post therapy.
How many cycles you want to give? How many cycles?
Sir, for if it is a total neoadjuvant, 6 weeks.
Total neoadjuvant. We are talking about total neoadjuvant here.
Neoadjuvant 6 cycles.
6 cycles.
4 to 6 cycles. 4 to 6 cycles.
Oh. So after that, like Dr. Sastry is asking you, how will you reevaluate these patients after say 4 cycles or 6 cycles of neoadjuvant therapy? How will you reassess?
Sir, with PET CT and again a pancreatic protocol CT is to be done, sir.
So your evaluation should always start with clinical evaluation.
Yes, sir. Patients.
Imaging evaluation foolproof?
No, sir.
That's the reason why you want to have a comprehensive evaluation. So how do you evaluate imaging wise?
Will rule out any distal progression of the disease or any distal metastasis.
Metastasis and new disease, yes.
And we'll look for ascites. We'll look for any liver as well to rule out metastasis. After that, we can proceed with the vascular anatomy to be reconfirmed, vascular involvement to be reconfirmed.
Are there any criteria for solid mass assessment after chemotherapy?
Yes. Complete response, partial response.
What are those? What is that criteria? What is the acronym?
Named criteria.
RESIST criteria.
And there has been modified RESIST criteria in the.
Yes. Two criteria, 2 years. Okay.
I'm not able to recollect.
Okay, do we have any? Yeah.
Was it given in this patient, neoadjuvant therapy?
Yes, sir, it was given, sir. Folfirinox was given.
How many cycles?
4 cycles, sir.
4 cycles.
So is after the therapy.
The lesion appears to have responded, but
So our, portal. We were more worried about the portal vein. No, artery was always free.
portal vein and SMV appears to be free.
Appears to be?
The tumor response is visible, sir. There is no change in contour of the portal vein, sir.
The
type of stent also it's in. What type of stent it's looking now?
It's sensor.
It seems it is a metallic stent. Second time has been put, it is replaced by the metallic stent.
Yes.
Go down, you see, clearly you can see the,
Yes,
Yeah.
sir.
based on the CT scan, do you think there has been a response?
Sorry, sir.
What
Is there any response?
Yes, sir. There appears to be response, and portal vein contour is maintained. There is the tumor appears to be away. There appears to be a maintained fat plane.
It's still,
And lymph node also has disappeared the previously seen lymph node. I would also like to see the thorax, CT thorax, to look for any pulmonary mets that might have developed or not.
that should be done when you are telling first time CT scan, that I would like to have a CT thorax included in my first CT scan protocol.
Yes.
Okay, there are no lung metastasis. I think we are crossing the time. So what is your now final treatment decision in this patient? Assuming that there is some response, but say that fat planes are still not very clear. You'll have to see the console. This unzoomed image is becoming a little difficult. You may not be able to exactly say. If it is status quo, what is your option? If there is slight improvement, what option? And how would you proceed? What kind of resection would you do?
Sir, if the patient's ECOG status is good and patient is surgically fit, I would like, and there is a response, I would like to go for staging laparoscopy followed by pancreaticoduodenectomy. Since it is a large head mass, it was a large head mass, I would like to go for a classical pancreaticoduodenectomy.
You would go for classical, you said.
For so many hips, you have seen the patient, you know the status of the patient, general condition, everything is in front of you.
I would like to go for staging laparoscopy followed by pancreaticoduodenectomy.
So what approach for a pancreaticoduodenectomy? Classical SMB first or SMA first, artery first?
And artery first.
Why do you want to do artery first here? Artery is nowhere.
Because in this patient, SMB first should be done, because earlier main portal vein was involved.
Don't change just because somebody is contesting. But any particular reason? You'll have to have your reasons.
Since in the previous
You always do SMB first or SMA first. There are people who do only artery first in all cases of head pancreas and with enough justification.
in this patient, since in the previous scan, main portal vein appeared to be involved, so SMV first approach would be of help. Before committing to the procedure, we will be able to assess for the resectability on table.
First is what? I don't understand. What is SMB first?
The classical approach, in which after cauterization will take the after cauterization, the head is lifted off the IVC, and then after ligating the Henle's trunk, will assess whether we'll be able to free the tumor from the SMV, and then we'll commit for resection.
So in those cases, the people think that SMA first approach is better because you just what you do is SMA first, you just try to disconnect the uncinate process, all the small vessels, and try to have SMA away from the thing, so that your assessment of the SMB, or even when you require a resection, it's better to have SMA first approach and That is the better tool for the lesions which resection or which have this type of evidence in the scans.
So what will you do? Whether will you how will you take care of the splenic vein in this patient? Because you said it is a portal vein involvement. Does the splenic vein make any difference to your approach?
I'm not sure.
Will you ligate the splenic vein or you will leave the splenic vein? What is your approach? How will you manage this thing?
Clinic vein appeared to be free, sir.
Okay.
Not
So what are the various ways of reconstructing the portal vein once you reset?
graft can be if we can
Yeah, this is the exact reason why Dr. Sastry was also pointing out you require to sit with the radiologist and reconstruct the images to see the extent of portal vein involvement. The size of the portal vein involvement decides upon what type of reconstruction, whether you're going to take a sleeve or you're going to do end-to-end anastomosis or you would need a graft. Okay, up to 1.5 centimeters of the portal vein dissection, you can reconstruct it end-to-end. If it is more than that, you will require a graft in this case. What are the preferable grafts which you will use in this patient?
PTFE. It can be a autologous graft or a synthetic graft. In synthetic graft, PTFE graft is preferred, and in autologous graft, IJV can be.
Sir, I think we can. We have already 15 minutes past 9. We can just ask, give your final comment and ask Sastry sir to Dr. Pradeep to invite other faculty.
Yeah, Dr. Pradeep, over.
I think overall, what are the downsides of their presentations? I think I felt that there is a lot of scope for improvement in the presentation and answering the questions. That's what I find, but they have done overall okay. So there are 4 questions, I think, questions session. I think probably one of the panelists can take those questions in a Q&A. In the meantime, we'll ask Dr. Professor Supe, Professor Kapoor to give their comments.
So one of the important point I would like to highlight that when you had a diabetes patient, onset was about 50 years. So in the discussion, diabetes should come in the pancreatic cancer when this is our one of the differences.
Good morning, Pradeep. VK Kapoor here.
Sir. Good morning, sir.
Morning. So first is that many students and unfortunately some textbooks do not differentiate between papilla and ampulla, but they are 2 different structures. Ampulla is the common channel formed by the lower end of the common bile duct and the terminal part of the pancreatic duct, the dilated. Papilla is the nipple-like projection on the medial wall of the second part of the duodenum where this common channel opens. So periampullary cancers are within 2 centimeters of the ampulla. Some texts say 1 centimeter also. So they include ampullary, a true ampullary tumor, a lower end cholangiocarcinoma, a small pancreatic ductal adenocarcinoma, a papillary tumor, which is on the papilla, and a peripapillary duodenal adenocarcinoma. So these are all included as periampullary cancers. If you see a mass on imaging, then it becomes a pancreatic head cancer. You said hemobilia. Hemobilia is bleed in the biliary system. EPT or endoscopic intervention would not cause hemobilia. It causes bleed, which is different from hemobilia. And you were not right in saying that post-EPT bleed is because we have cut through the tumor. Post-EPT bleed occurs even when we do a papillotomy for stone disease. It is not necessarily cutting through the tumor. It is the vessel which is running there, a branch of the gastroduodenal artery, or the superior pancreaticoduodenal artery, which gets divided and bleeds. The classical picture described in some textbooks of a papillary tumor or a peripapillary duodenal tumor, that there is sloughing of tumor, relief, transient relief of jaundice associated with melena. Yes, if it is there, it helps, but it is not seen very frequently. So if it is not there, it doesn't rule out. And this happens only in papillary and peripapillary duodenal tumor, not in an ampullary or a lower end cholangiocarcinoma. A previous cholecystectomy, yes, by and large rules out the differential diagnosis of gallbladder cancer, but we have to keep in mind that more and more surgeons are now resorting to a partial or a subtotal cholecystectomy in case of a difficult gallbladder, which I fully agree and endorse. And in that situation, especially if stones are left in the residual gallbladder, you can have a gallbladder cancer even after a partial previous cholecystectomy. So it is only imaging which will tell you whether a residual gallbladder is there or not. Whenever you talk of borderline resectable pancreatic cancer, you have to start by saying that there are several definitions which differ from each other to some extent. And the most important vessels for any definition of borderline pancreatic cancer, which should be mentioned first, are the superior mesenteric vessels. Then you go to the other vessels. When you talk of vascular involvement on imaging in any pancreatic cancer, or for that matter, even other cancers, you have to use the terms, the specific terms. And all students, when you give an answer, please make sure that you mention all the keywords in your answer. So you have to say abutment, you have to say encasement, you have to say occlusion, thrombosis, the angle of contact, the length of involvement, and whether it is reconstructible or not. Because these are the terms which are used in defining borderline resectable pancreatic cancer. Tumor marker, the CA99, is used in one of the definitions of borderline resectable pancreatic cancer, the ABC, the anatomy, biology, and the clinical status of the patient classification. So from that point of view, it becomes important. And if the tumor marker level, and I don't think it is 100, if I remember correctly, it's 500, then the patient becomes a candidate for neoadjuvant treatment. Some groups use it as an indicator for obtaining a PET scan and doing a staging laparoscopy if they don't do it as a routine. And of course, the prognosis. A general comment, whenever a question is asked, you have to listen to the question properly, give a pause of a few seconds and answer the question first. Twice you faltered on that. When Dr. Sastry asked you anatomy of the first jejunal vein, you started answering the significance of involvement of the first jejunal vein. He didn't ask you that. He asked you the anatomy of the jejunal vein. Similarly, when he asked about the rationale of neoadjuvant chemotherapy, you started talking of results. See, the problem is that our mind is preset. As soon as the word neoadjuvant is mentioned, I think that the examiner is asking the results. No, you have to listen to the question properly. And I thought that in the post-NACT CT also, the vein was involved, because the angle of contact, if as much as I could see, was still about 180 or maybe even more than 180 degree. So students, this time, I'm offering a review written by Dr. Kailash Kudia, who's at AIMS along with me on borderline resectable cancer. The title is Pancreatic Cancer, Whether to Cross the Border. Please send me a mail, vkkapoor.india@gmail.com, and write BRPC. So since Kailash is not there, I'm taking the credit. He has written the article, but I'll send you a copy of that article. All students must read that article, because whenever you have a case of pancreatic cancer, this BRPC discussion will come during the discussion. That's all. Thank you. Thank you, Pradeep.
Thank you, sir. Thank you, sir. So that's super, sir. Any comments, or? TD, there are a few questions on the Q&A.
What percent of the direct bilirubin should be elevated to call it? Usually, see, obstructive jaundice, there is intrahepatic cholestasis also. So you have to take other part also in the consideration. Only, but generally it is taken at more than 50%. But you have to combine other parameters also to say this. Second is involvement of contraindication for the operation. But when you are ligating for jejunal rod, there is a chance of congestion in the jejunal loop. So we try to resect a little bit of more jejunum so that there should not be congestion when you are doing a pancreaticojejunostomy. So that is very, very important. So what is the preferred in a CT? The preferred, that's why I was talking to Payal that she must know the SPEC-5 trial has included borderline pancreatic cancer, and as well as they have also included with gemcitabine, and which has shown clearly the superiority of the FOLFIRINOX over the gemcitabine. So that is the preferred, provided the patient's general condition are satisfactory, much better to tolerate the surgery. So first jejunal branch, as I said, usually can be ligated, and a little bit of about 5 to 6 centimeter of the more jejunum has to be sacrificed. As we take about 10 to 12 centimeter, it has to go to about 15-20 centimeter. So that should drain the properly jejunum. That is the criteria. It's not a contraindication for the surgery.
Yeah, coming to the neoadjuvant, I think in a good risk patient, a FOLFIRINOX is preferred, and probably not a good risk patient, probably GemCap with paclitaxel gets the next option to be preferred in this neoadjuvant setting. If there are no comments, can we wind up, sir?
Yes, sir.
Yeah, I think yeah, it's done fairly well. Of course, there is always a scope for improvement. Do keep in mind those small minor or pointers which Dr. Kapoor has given and throughout. Do keep them in mind. We've done okay.
Okay.
Shall we?
Yes, sir.
Yes, sir.
Thank you, Payal. Thank you, Professor Sastry, Professor Yadav, Professor Ramakrishna Prabhu, Professor Kapoor, and Professor Supe, and Professor.
Thank you.
Thank you.
Thank you.